Can you, can you just put him on the phone for a second? I just want to hear his voice. There's my guy. How you doing, buddy? I would love to hear your song.
You should go home. Oh, that is the last place I want to be. You sure you shouldn't see your baby?
For context, the doc here, who was pregnant, had PV bleeding. PV bleed in first trimester is suggestive of spontaneous abortion or miscarriage. On ultrasound, which she performed herself, we saw that the uterus was empty with no embryo or fetus and was collapsed. There was the thin endometrial stripe and it didn't lodge fetus or any retained products of conception. The uterus findings suggested complete expulsion of fetus, that is complete abortion.
I checked myself. Uterus is empty, barely spotting now. I'm fine.
In incomplete abortion, bleeding would still typically occur due to the retained products of conception, while it would subside quickly in complete abortion, like this case.
Oh, honey, I'm so sorry. Oh, I shouldn't have bought that stroller.
It's an unfortunate situation here. Since complete expulsion has been confirmed by ultrasound, no further intervention like dilation and curettage or medications are required. For a case of miscarriage, every patient should be monitored for heavy bleeding, severe abdominal pain, foul-smelling discharge or fever, as it could indicate septic abortion that could still occur due to undetected retained products of conception still present. Pelvic rest is advised. Menstruation typically resumes in 4 to 6 weeks, but it can vary. Ovulation may occur as soon as 2 weeks after the abortion, so contraception should be considered immediately if the patient doesn't wish to become pregnant again.
Losing a kid is hard on everybody.
The loss of a child is one of the worst experiences a human has to face in his entire lifetime as a parent. Not only this, it definitely does take a piece of the soul of every medical staff involved. The loss of an elderly patient who had several comorbidities and was in the ICU for several days can be somehow digested, but the sudden loss of a child who was completely fine a day before is simply unbearable. And telling a parent that their son or daughter has died is one of, if not the most heart-wrenching thing you would unfortunately have to experience as a doctor, especially if you happen to work in the ER or the ICU.
That's as hard as it gets. We do these debriefs to try to give a sense of closure, meaning to difficult cases so that they won't linger.
Debriefing about the unfortunate situation after the death of patient is a good practice. First of all, it helps for emotional processing when we take time to actively acknowledge the situation, do a clinical review, and identify what went well and what could be improved. Learning points could also be discussed for better future care. If everything was done right, you gotta accept the situation, acknowledge the loss of the patient, realize that not everyone you treat could be saved, even with the best care, and move on. But it's definitely easier said than done, especially if a pediatric death occurred.
But trust me, the kids you'll lose will linger.
And it also doesn't get better over the years of practice. Having to face death and deliver bad news to the family never gets better or easier in medicine.
So what do? I did my residency at Big Charity in New Orleans. And day one, I got a kid, 5-year-old boy, accidentally shot by his brother, playing with dad's gun. Worried he was gonna get in trouble, right up until he coded and died.
He coded, meaning he had a cardiac arrest. The resuscitation was unsuccessful and he was pronounced dead. It's always the bad memories that feel fresh, even though years have passed. The good memories of saving patients' lives feel distant because we don't even think about it. We were expected to do it, and so we did. We only remember the cases where we committed mistakes, the cases where we couldn't save the patient, the surgery that went wrong, the patient that scolded us, the negative interaction with seniors or doctors from other specialty. All these bad memories remain stuck with us, and we ruminate on the thoughts of bad memories, and hence it always feels fresh and difficult to let go.
Then I asked myself, like, what do I do with this kid? Where do I put this feeling?
One important thing is that these bad memories or mistakes or unfortunate situation affect us to the point where we question, why am I even in this field, and why these things seem to happen to only me, or whether I am not good enough for this. But we should never let these circumstances define our skills or intellect or expertise, and we gotta consciously put efforts to become better every day so that these thoughts won't have a refuge in our mind.
And I found myself walking all night. I was walking and walking and walking, and I found myself back at the gates of Big Charity Cemetery, and I'm looking at all those mausoleums and those crypts, and I'm thinking to myself, okay, well, that's what I need.
I think sharing these sad and heartbreaking experiences to your close one, your spouse, or your family members or friends does tremendously help, rather than bottling up these untold and repressed emotions of fear, guilt, self-doubt, and grief.
I just need a safe place where I can put these feelings
we got
in.
patients throwing punches in chairs.
Okay, everybody, let's get back to it. Just remember the Employee Assistance Program is available, as are Kiara and myself, if anybody needs to talk.
That's great. Seeing deaths every day as a doctor, especially in specialties like emergency medicine, neurosurgery, or oncology, or in ICU, imposes a psychological toll on the medical staff. One major effect is called cumulative grief. As doctors, we don't always have time to process each death. Over time, small unacknowledged losses accumulate, and this can lead to emotional numbness and desensitization, but it would convert into unexpected breakdowns later. This cumulative grief requires some downtime to process. Maybe we could talk it out with friends, colleagues, or a psychologist. If not addressed over time, this would contribute to physician burnout and mental illness.
Where's McKay?
Central 11 with our UTI accounting assistant while we keep her boss on ice in North 2.
Robbie, critical case flying in, possible MDMA overdose.
MDMA, or methylene dioxy, methamphetamine, or ecstasy, is a psychoactive stimulant with hallucinogenic properties. Overdose can lead to life-threatening complications, especially due to hyperthermia, which can cause skeletal muscle breakdown or rhabdomyolysis, disseminated intravascular coagulation, and multi-organ failure. Other features of overdose would include agitation, anxiety, confusion, delirium, and can even lead to coma. The primary management hence revolves around managing hyperthermia with aggressive cooling with ice packs to groin or axilla, or IV cold fluids or evaporative cooling with fan and mist. Benzodiazepines like lorazepam are also given for managing agitation, seizures, or hyperadrenergic state if present. ICU admission is required if temp is more than 40 degrees Celsius with altered mental status or seizures or acute kidney injury or severe hyponatremia. The patient may even need intubation, vasopressors, or dialysis.
High temp en route from Pitt Fest, 5 minutes out.
Stay here, set up for that. Ahmad and I got chairs.
Hey, is everything all right with Collins? Something's bothering her. I asked her about it. She said she didn't want to talk to me about it.
Oh, imagine that. She probably learned it from you. Seriously? You just gave a speech titled How to Literally Bury Your Feelings.
Rather than burying feelings, we gotta acknowledge and express them with your peers or family. Bottled up, buried emotions leads to complicated grief and burnout.
Now, if you'll excuse me, I gotta break up a fight.
No, you want to control your wife, man?
Shut up, man!
Too much crowd with long waiting time definitely does breed contempt with each other and hence the resulting aggression and violence.
Hey, Olsen, it took you long enough. Calm down.
No, don't tell me to calm down. How hard is it to put a mask on your kid? He has allergies, you Fauci zombie.
Is she talking about mask allergy? If it's the case, it could be latex allergy, as some masks have latex in their elastic bands. Wearing it can cause itching, rash, or contact dermatitis around the ears or face. Or there could be allergy to mask materials like polyester, dyes, and adhesives. This can also cause similar symptoms of contact dermatitis. The solution would be to use non-latex, 100% cotton inner layer masks. But maybe she is one of those people who doesn't believe in masks?
Allergies! Hey, that's enough! Jesus almighty, I don't believe what I'm seeing. What do you people think you are, huh? This ain't Philly. This is a hospital, for Christ's sakes. What's the matter with you?
I've never had to shout like this, but I've seen and observed that some patients wouldn't even hesitate to put hands on doctors who were just trying to separate the fight and maintain peace at their workplace. Here, it's a result of the crowded hallway due to insufficient beds in the hospital. Sometimes patients trade blows while just being in line outside of the doctor's room as well.
You call yourselves adults? Huh? There are children in here. You should be ashamed of yourselves. Fucking ridiculous. All I did was offer to put a mask on her child who's been coughing for over an hour, and now I'm missing half my goddamn. First of all, like masks are bullshit.
Masks do reduce transmission of respiratory droplets. When someone coughs, sneezes, talks, or even breathes, droplets come out. Masks block many of these, especially larger droplets that could carry viruses. If you're infected and wear a mask, you're less likely to infect others, which is called source control. Some tight-fitting masks can also filter incoming air, providing some protection to the wearer too. Overall, masks are protective. They may not be 100% protective, but nothing is 100%.
And B, it's an allergy. He's allergic to cats, dander, like I
Oh, so she is talking about allergy to cats and not masks. But it doesn't make sense. Allergy to cats or other allergens won't merit you to not wear masks. You absolutely should wear it if you're sneezing due to allergies, especially in public or healthcare settings, because you could coincidentally have a viral infection too, and early viral symptoms often mimic allergy symptoms. So, since sneezing spreads respiratory pathogens regardless of the cause, you should wear it. The only reason to not wear a mask in allergies is if you are allergic to the mask itself, in which case we could use a hypoallergic mask or a face shield.
My sister, shut up right now, please. And only answer the questions I ask. What happened to the tooth? Did you swallow it?
I don't think so.
Tooth being broken partially is a tooth fracture. If it was knocked off completely, is likely an avulsion injury. For tooth fracture, treatment depends on the severity or type of fracture. For avulsion of a permanent tooth, time is critical. So, we gotta refer the patient to a dentist to ideally replant within 60 minutes. We could provide analgesics, antibiotics, and supportive care meanwhile.
I think it's still in my hand.
It sure is. I hope you both have all your shots.
What do you mean, like vaccines?
Again, another instigator trying to start a debate on vaccines here.
Jesus, please don't stir this pot. Let's take these ladies back and get them treated. Separately.
Stick with me.
Come on. Excuse me, sir. You're not allowed back there.
Unless what? I start a fight? Become homeless? Apparently that's what it takes.
I understand your frustration. I promise you'll be seen as soon as a provider is available.
But how can they become available if new people keep cutting the line?
As pointed out before, patients would be really sensitive about the wait time. Having a queue of people to be checked one after the other works in OPD settings where the cases aren't emergent. But in emergency, we gotta serve patients as per the urgency of the medical treatment based on the severity of their disease. It's not a queue or line system, but rather a triage system where the most critical patient will always ideally have to get the care first, even if he arrived just few moments ago.
There's no line. We see patients by severity of need. As soon as we have your tests and labs, you will be seen.
This place is unbelievable.
This is just unawareness displayed by the patient and him not trying to understand how the ER works. He doesn't require emergent care, so he has to give way to patients who require emergent care. It's as simple as that.
Run around after run around. Hey, what's up, Eric Estrada? Still keeping your eye on me?
Always, my friend. Always. Who's Eric Estrada?
Shame on you, Chip.
I guess an American actor from the TV series Chips or California Highway Patrol, known for his role in the series as a charismatic, risk-taking motorcycle patrol officer.
Know your television history, and thank you.
Yep.
Crazy people.
If you do get my tooth out, I don't want it. After it's been inside that woman!
Reattachment wouldn't be possible.
Type 2 fracture into the dentin.
So it's a tooth fracture, particularly a type 2 dental fracture, which is also called an Ellis class 2 fracture. It refers to a traumatic injury to the teeth that involves both the enamel and the dentin, but does not expose the pulp. Here, on examination, yellowish dentin is visible beneath the white enamel. The tooth becomes sensitive to air, temperature, or touch. There is no pulp exposure with no bleeding from the center. Emergency management in this case includes covering exposed dentin to protect from thermal or pain sensitivity using materials like calcium hydroxide, glass ionomer, or zinc oxide eugenol. We could also use dental cement. We gotta provide analgesics like paracetamol or ibuprofen for pain relief.
Seal with dental cement. Prescription for Pen VK, soft diet.
Pen VK means penicillin V, a broad-spectrum antibiotic to be used here to prevent infection. Amoxicillin, doxycycline, or clindamycin are other alternatives commonly used. They are usually considered for type 3 fracture where there is exposure of the pulp with high risk of bacterial contamination.
Follow up with the dentist 1 to 3 days for a crown.
First, the patient should avoid hot or cold foods. The patient should also avoid further trauma, meaning she should only have soft diet and shouldn't bite with the injured tooth. Then, she should be referred to a dentist within 24 to 48 hours ideally for restorative treatment like composite resin bonding or crown placement. X-ray could also be done to rule out root or alveolar injury.
You handle Sphinx while I check on Ali?
You got this? Don't we, partner?
Yes. Totally got this.
How we doing in here?
You should write that bitch a script for calcium because I didn't even hit her that hard.
Calcium deficiency can contribute to loose teeth in the context of trauma. Calcium is essential for bone density and enamel and dentin formation, and hence chronic deficiency of calcium can weaken bone and tooth structure, making them more susceptible to damage or periodontal issues. Vitamin C deficiency can actually directly cause loose teeth without the need of trauma. Vitamin C is critical for collagen synthesis, which is important for integrity of gums and teeth. Its deficiency, also called scurvy, can cause bleeding gums, swollen gums, periodontal breakdown, and loose teeth.
Too much almond milk in your soy lattes. That doesn't even make sense.
You know, most commercial almond and soy milks are fortified with calcium, so they end up having a higher percentage of calcium than cow's milk.
Boom! She was fact-checked right there and then. Commercial almond milks often have low protein, carbs, and fats, but more of calcium and vitamins as they are fortified with calcium, vitamin D, and B12.
Prepped with betadine and draped.
Very nice. Let's have a closer look. Dr. King, can you please grab me a 10cc syringe, a 20-gauge needle, and some sterile saline?
Pluck it out, stitch me up, and send.
A very demanding patient, difficult to deal with. Some patients turn out to be non-cooperative and too skeptic about the medical procedures being done on them or meds being prescribed, even though we are just trying to help them as much as possible for their own good.
Me home. I've got to get back out there to my kid.
Well,
He's still waiting to be seen, by the way.
Afraid it's a little more complicated than that. You got yourself a fight bite.
A fight bite is a clenched fist injury that occurs when someone punches another person's teeth, causing the puncher's skin over the knuckles or hand to be cut by the other person's teeth. Here, additionally, the fractured tooth segment became embedded in the puncher's hand, likely the knuckle area. There is high risk of infection since human mouths carry many bacteria. When the tooth and saliva from the injured person enters the puncher's hand wound, bacteria that comes along with it can cause a serious infection. Common bacteria include Eikenella corrodens, Staphylococcus, and Streptococcus. The emergency management in this case would include wound cleaning and irrigation with thorough flushing of normal saline to reduce infection risk. The removal of the tooth should be attempted in sterile settings. Then the patient is put on broad-spectrum antibiotics like amoxicillin plus clavulanate. However, depending on the injury severity, surgical consultation may also be required.
Which means a couple things. First, we need to determine if the bite extended into the joint space.
If a fight bite injury extends into the joint space, which is the metacarpophalangeal joint of the knuckle area, this could cause infection into the joint called septic arthritis, and it's a medical emergency. Here, bacteria enter the joint space, causing infection of the synovial fluid and joint tissues. This leads to rapid inflammation, pain, swelling, and decreased movement. If untreated, it can cause joint destruction, permanent stiffness, loss of function, and even spread of infection to the bloodstream, resulting in sepsis. Since delay in treatment can lead to irreversible joint damage in as little as 24 to 48 hours, it requires urgent surgical consultation. So, wound examination is important to rule out tooth fragment extending into the joint space. If the tooth had impinged on the joint space, penetrating the joint capsule, the possibility of septic arthritis is high, and so joint drainage and irrigation with arthrotomy or arthroscopy is required to remove infected fluid, typically done in the OR by the orthopedic team. Empirical intravenous antibiotics targeting oral bacteria are also to be started, with IV amoxicillin plus clavulanate or IV clindamycin plus ciprofloxacin.
If it did, you're going to need IV antibiotics on a trip to the OR to see a hand surgeon. Pinprick and a little burning.
He's about to anesthetize the site with the help of local anesthetic injection of lignocaine to numb the area so that removal of the tooth becomes easier.
An operation?
Well, you're just shouting a minute ago about infection. And with good reason. While I am sure you are in the clear for rabies and HIV,
so the tooth has been removed carefully under anesthesia.
Human mouths are filthy, some more than others.
How can you tell if it's bad?
Now, the wound examination to rule out risk of septic arthritis involves finding out whether the tooth had impinged on the joint space by breaching the joint capsule, which means finding out whether the wound is communicating with the joint space after removal of the tooth. A diagnostic test called saline load test is used particularly in fight bite injuries to assess the integrity of the joint capsule. Here, a needle is inserted into the joint space of the involved metacarpophalangeal joint. Sterile saline is injected into the joint. 1 to 2 milliliters may suffice for finger joints. Then the wound is observed to see if fluid leaks out. If fluid extrudes from the wound, it confirms joint penetration. If no fluid appears, the joint capsule is thought to be intact.
Great question, Dr. King.
I'm sorry?
I am going to inject some sterile saline into your knuckle joint, which you won't feel because of the anesthetic. If it comes spraying back out of the bite wound, we'll know. Ready?
I guess.
If fluid extrudes from the wound, we assume that the joint capsule has been breached. This means the patient has a contaminated joint space with high risk of septic arthritis. The patient is immediately put on IV antibiotics, and joint drainage along with irrigation with arthrotomy or arthroscopy is done in the OR by the orthopedic team.
There she blows.
Shit.
This confirms that the tooth had compromised the joint capsule. She is in high risk of septic arthritis, where the joint can get inflamed and filled with pus due to the oral microorganisms being transmitted from the teeth into the joint, and hence needs surgery to wash out the joint along with IV antibiotics.
Are you serious? You hear that, you bitch? I've got to have surgery thanks to you. Good. You assaulted me. Damn right. And now that next time you'll keep your masks and opinions to yourself.
She is the one who should keep her opinions to herself, it seems.
You okay?
Yes.
3 grams Unison IV. Call the OR.
Unison is the trade name for ampicillin sulbactam, a similar drug combination to amoxicillin clavulanate mentioned earlier.
Tell them we have a fight bite that needs to be washed out, then go take 20 minutes in the lounge. I'll come find you if I need you.
Well, I don't need a break.
Yes, you do.
Seeing deaths of multiple patients in the ER has catched up on her. She needs some downtime to prevent burnout.
Okay. Oh, did you want me to tell the surgeons to go no mask for surgery?
What?
Good point. She doesn't believe in masks and doesn't believe that masks prevent transmission of infection from self to others nearby. So, what's her take on others wearing masks for her safety?
Well, those of us who save lives for a living believe strongly that masks minimize risk when it comes to spreading disease and infection, but I want to respect your beliefs. So, what do you think? With or without for surgery? Without?
I want with.
Just hypocritical, to say the least. She wants others to wear masks so that she is protected, but will punch someone if she or her child has to wear one for others' safety.
Good call.
Helicopters here, cafeteria, send the ice?
Yep, everything they got.
Preparing for the hyperthermia case here due to ecstasy overdose.
Hey, I hear they're gonna start you working on the Middle East peace plan, not since the Dalai Lama or Gandhi.
Baby, right to. You should have seen me. It was inspiring. Also terrifying, a little bit shaming.
Holy trinity of crowd control. Hey, can we pick it up in here, please? Overdose is here.
Pitt Fest OD.
Keely Ralston brought to the first aid tent at Pitt Fest with altered mental status and fever. Temp too high for a field thermometer.
Too high to register on a field thermometer means the temperature is above 107.6 degrees Fahrenheit, which is a life-threatening hyperthermia. This high temperature can cause rhabdomyolysis, disseminated intravascular coagulation or DIC, acute renal failure, seizures, coma, and arrhythmias. This requires rapid cooling to lower the core temperature as soon as possible. We can use ice packs to neck, groin, and axilla, evaporative cooling by undressing the patient using water and fans, cold IV fluids, cooling blankets, ice water immersion if possible, chilled gastric or bladder lavage. Antipyretics like paracetamol and ibuprofen are not effective in hyperthermia.
Intubated en route.
We gotta cool this lady down.
Get some ice packs, head, neck, groin, send off a rainbow.
On it.
Send off a rainbow means drawing multiple blood tubes of different colored cap tops for blood tests. We specifically look for creatinine kinase and myoglobin for rhabdomyolysis, electrolytes like potassium to check for hyperkalemia, RFT for increased creatinine due to acute kidney failure, LFT, ABG for acidosis, and coagulation panel for increased PT and APTT in the setting of DIC.
Heart rate 132, BP 210 over 120.
BP 210 by 120 with heart rate 132 is a state of hypertensive emergency with tachycardia. There's likely signs of end organ damage too at this point, with neurologic, cardiac, visual, or renal damage.
20.
Jesus, that's high.
4 of Ativan in the field.
Pupils are dilated, definitely MDMA overdose.
In MDMA overdose, the pupils are typically dilated because sympathetic overactivity causes wide reactive pupils. This is often bilateral, and pupils are equal in size and responsive to light. MDMA is a stimulant that increases serotonin, dopamine, and norepinephrine. This triggers increase in heart rate, blood pressure, and body temperature along with dilated pupils but responsive to light. If pupils become non-reactive or unequal, we have to suspect brain herniation, seizure, or prolonged hypoxia. Other drugs that cause dilated pupils include stimulants that increase sympathetic activity like cocaine, amphetamines, and even caffeine, or anticholinergics that decrease parasympathetic activity like atropine, TCAs, or serotonergics adrenergic drugs like SSRI or hallucinogens like LSD.
So, Dr. Mohan, how do you want to treat the BP?
Beta blockers?
No.
So the increase in BP here is caused by central sympathetic activation, causing increase in catecholamines like norepinephrine and dopamine. The first line treatment here would be benzodiazepines like lorazepam that reduce BP and heart rate by decreasing central sympathetic outflow. If benzos fail, we could add other antihypertensives, but with caution like labetalol or nitroprusside. Regarding adrenergic receptors that are relevant here, alpha-1 is responsible for increase in BP due to vasoconstriction, while beta-1 is responsible for increase in BP via increase in heart rate and contractility, hence leading to increase in cardiac output. Beta-2 cause vasodilation, leading to decrease in BP, opposing alpha-1 activity. Labetalol blocks both alpha and beta receptors, hence decreasing BP overall. Beta blockers, on the other hand, would only block beta receptors. The alpha-1 receptors remain unblocked, so their unopposed activity to cause vasoconstriction would rather increase blood pressure, unopposed, meaning the usual counterparts that oppose them are beta-2 receptors that cause vasodilation, and beta blockers block them too, leading to only alpha-1 receptors being functional and unopposed in blood vessels. This would rather increase blood pressure and hence could cause severe end organ damage and death due to severe hypertensive crisis. Another drug contraindicated in these cases would be antipsychotics like haloperidol that would lower seizure threshold and worsen hyperthermia.
Unopposed alpha could kill her. 4 more of Ativan, please.
Seriously?
Ativan is the trade name for lorazepam, the benzodiazepine to be used for hypertensive crisis and preventing seizure here, in this case of hyperthermia. Regarding the dose, lorazepam can be given as 4 milligrams IV over 2 minutes and can be repeated over 10 to 15 minutes.
She might need another 40. Hypertension and tachycardia from MDMA centrally mediated. Ativan is the drug of choice.
As said before, the increase in BP due to MDMA here is caused by central sympathetic activation, causing a surge in catecholamines like norepinephrine and dopamine. Benzodiazepines act as GABA receptor agonists and enhance the effects of GABA, the brain's primary inhibitory neurotransmitter, helping here to decrease sympathetic outflow from the CNS. This decreases BP and heart rate and help treat the hypertensive crisis. Besides this, benzos also help treat agitation, prevent or treat seizures, and prevent serotonin syndrome, all of which are relevant in this particular case.
Damn, core temp 107.3.
Okay, can we get another hose in here before she fries her brain, please?
At this temperature, protein denaturation begins in the body, blood-brain barrier breaks down, and there is risk of DIC, rhabdomyolysis, seizures, multi-organ failure, and death. So we gotta exhaust all cooling measures here.
Let's go. Come on.
I'll be right back.
Hi. You look lost.
No, it's my assistant who actually seems to have been misplaced. I mean, how long does a CT take?
Why would a patient party be so afraid of what's going to happen unless the patient is a child?
Certainly not this long.
You can get pretty backed up. Can I get you a cup of bad coffee, dry sandwich?
No, thank you.
How about a cold LaCroix from my secret stash in the lounge? I'm going for one myself. I'm freaking addicted.
I'm good on drinks. Can you take me to radiology?
Yeah, right this way.
In real-life practice, there could be a couple of reasons for distracting a patient party from the doctor-patient communication. One is definitely to maintain patient privacy, especially in sensitive exams like genital, rectal, or psychiatric assessment, where we may politely ask family members or patient party to step outside or engage them in conversation elsewhere to protect the patient's dignity. Some family members may become overly anxious or interruptive, which can affect the doctor's ability to conduct the exam properly. Engaging them elsewhere helps maintain focus. It could also be done to get a better history or, like in this case, under suspicion of something malicious happening to the patient. Distracting them is also done to avoid bias in assessment. In cases where the patient party might influence the patient's answers, separating or distracting them helps for independent evaluation.
Piper, while we still have a few minutes, there's some things I want to say.
Yeah, I use protection. I know. I'm sorry.
Totally.
It's a mistake.
Totally. I'm a part of the street team here. It's a group of doctors and nurses who go out in the community and help people who can't or won't ask for help. Addicts, unhoused, runaways.
The portrayal of a doctor-patient communication is top-notch in this series. It feels almost too real.
And I'll be honest with you, Piper. I think you need some help.
What are you talking about?
If you're in trouble, we can help you.
I'm not. Okay?
Just like the reaction of a victim of child abuse earlier, the patient also seems oblivious of what's happening to her. Victims don't often know what is actually happening until it's too late to realize.
And if we're done here, I think I'd like to go.
Will you at least take a look at this? There's a list of resources on the back.
I don't need that.
Yeah, I know you don't have a phone, but if you could just take my number, okay? You never know.
A doctor is offering her number for help, and the patient is still reluctant and confused.
Where's Laura?
How about taking the pen? If you ever feel unsafe or in danger, call this number. It's a national hotline. There's somebody on the other end 24/7. A trained professional who can help with anything.
She's a really good doctor, trying to help via whatever means is possible or appropriate to the patient, who seems too afraid of her boss to even open up to a doctor in private space.
I have all the help I need. I want to go. Now.
Okay, I'm gonna count. 1, 2, 3. Gentle, gentle, gentle. Houston, we have splashdown.
As we enumerated before, apart from undressing in ice packs and cold IV fluids, the rapid cooling techniques involve evaporative cooling by spraying water and using fans, cooling blankets, chilled gastric or bladder lavage, and even ice water immersion if possible, just like what was done here. Ice water immersion is the fastest and most effective method of cooling a severely hyperthermic patient, such as someone with MDMA overdose, exertional heat stroke, or neuroleptic malignant syndrome, especially when the core temperature is more than 105. Here, we have to submerge as much of the body as possible in ice water from the neck down. Head and airway should be kept clear. Arms can remain out if needed for IV lines or monitoring.
Good luck. See you on the next one.
Yep.
Temps down to 107.1.
How long does she need to stay in the ice?
So, the goal of ice water immersion is to cool down the body till 39 degrees Celsius or 102.2 degrees Fahrenheit, then stop and remove the patient from ice water. This is because cooling below this temperature can cause shivering or hypothermia. The cooling methods, including ice water immersion, have possibility of overshooting, leading to large decrease in temperature, possibly causing hypothermia, so cooling till a temperature above normal till 102.2 is recommended. After removal, the patient is to be dried off and monitored for rhabdomyolysis and rebound hyperthermia.
Dr. Santos.
My PB in the ice is 13 minutes.
Dr. Santos.
Until her temp is normal.
Wrong. You pull her out at 102, otherwise we could overshoot and cause hypothermia.
Heart rate 120, pressure 198 over 116. More Ativan? Another 4, please.
Looks like lorazepam is working to decrease the BP and heart rate via central inhibition of sympathetic outflow. It is to be repeated cautiously, monitoring respiratory rate, otherwise patient could go into respiratory depression and arrest.
Why is she on the ice, Dr. Santos?
To bring her temp down.
Wow, state the obvious, yet still don't answer the question.
Ice water immersion is used because it is the most rapid method to reduce dangerously high core body temperatures. We gotta stop body proteins from denaturation and enzymes from stopping to work, and also reduce the risk of multi-organ failure, irreversible brain damage, and death as soon as possible. And the most immediate and rapid way to cool down the body is to immerse it in ice water.
Could we bring it down to less of a chance for permanent damage to the brain, liver, or kidneys?
Exactly. Was she sweating?
Profusely.
What if she wasn't, Dr. Santos? What if she was dry as a bone?
So, this is a case of MDMA overdose, which accounts for increase in sympathetic outflow, causing increased metabolism, vasoconstriction, and impaired central and peripheral thermoregulation. This leads to hyperthermia. Sweating is also regulated by sympathetic outflow, and hence it would be seen here too, profusely indeed, as the body tries to increase heat loss via sweat and counter hyperthermia. However, the interesting thing about sweating is that the neurotransmitter involved peripherally in sweat glands is acetylcholine, and muscarinic receptors M3 are involved. With anticholinergic drugs like atropine, this receptor would also be blocked, leading to lack of sweating and dry skin, along with lack of other secretions too. Hence, atropine or belladonna poisoning would cause symptoms like dry eyes, dry mouth, and dry skin due to absence of secretions. Due to lack of sweating, the body can't remove excess heat. The heat keeps on accumulating due to metabolism but can't be dissipated in the form of sweat. This results in hyperthermia. Hence, anticholinergic toxicity would result in the patient being hyperthermic too, hot as a hair and dry as a bone, primarily due to lack of sweating.
Then we'd have to think anticholinergic overdose, not sympathetic.
Very good.
The animosity here, trying to one-up each other.
ETA now.
That's another 4 of Ativan.
Rectal temps down to 105.
Okay, moving in the right direction. We might get lucky here.
The treatment is working. The patient could be saved if irreversible damage to the brain hasn't occurred yet.
Double trauma at the back door, auto versus pedestrian, before hitting the telephone pole.
Likely an ortho case.
You got this? Yep.
Dr. Ravi, I finished with Dr. Zeki, the therapist upstairs.
Yes. How'd that go?
Well,
excellent.
The case of malingering whose son had malicious thoughts of harming others and ran away from the hospital when confronted.
Have you heard from David?
No.
David's the therapist. You think that he's still gonna pick you up today?
I think so.
Okay.
The son needs a visit to the psychologist more than the mother here.
Robbie, here they come.
Okay, well, you're medically clear, so why don't you stay here for a little while longer in the hopes that he does? I still would like him to talk to somebody. Perla, this is Teresa. She's a friend of mine, so I expect concierge service, yes?
VIP treatment.
Thank you. You're in good hands. Just let me know if David shows up or if he calls.
Dr. Robbie is a true professional. A child psychologist or psychiatrist would be helpful for the son. The school where he goes and his teacher should also be informed.
Good boy. Good boy. Walter Purnell, 52, walking his dog in the crosswalk, got struck by a Chevy Impala at low velocity. Ambulatory on scene, no KO, no neck, chest, or belly pain, good vitals.
Whoa, major road rage.
Definitely needs sterile dressing of the wound and antibiotics.
Yeah, the car didn't hit me so much as throw me, but I slid for a good 10 feet. Of course, this is the first day I've worn shorts all left in here.
No deformity at the knee or ankle. Distal pulse is intact.
We look for distal neurovascular status, which refers to the function and integrity of the nerves and blood vessels distal to an injury site. It's a part of orthopedic examination. It helps detect vascular compromise and early identification of limb ischemia, and also help assess nerve injury if present. For vascular status, we check for pulse distal to injury, which would be dorsalis pedis in this case. Capillary refill time, skin temperature, and color for pallor or cyanosis are also to be checked. For neurologic status, we check for sensation and motor function like active movement of toes along with reflexes.
4 of morphine so far.
Yeah, feel free to be more generous.
Don't worry, we will patch you up. We will get you right. Who's your friend?
Oh, this is Crosby, who thankfully barked and warned me, so I had half a second to try to move out of the way.
Crosby, you're a hero. Donnie, you think you can find a milk bone for our little lifesaver here in the doctor's lounge?
Absolutely. I'll take good care of him.
Can he stay with me? He's a very good boy.
High risk of cross-contamination of wound merits not having too many people in the dressing room, let alone animals.
No doubt. Let's get you settled first. You're going to South 20. Is that the driver?
28-year-old lady had her seatbelt on, clipped the guy with the dog, and went straight into a telephone pole.
The history of having a seatbelt is important to rule out seatbelt injuries. These are trauma patterns that occur due to the restraint forces of a seatbelt during a motor vehicle collision. While seatbelts save lives, the force they exert during rapid deceleration can cause characteristic blunt trauma. The common types of seatbelt injuries include seatbelt sign, where there is linear abrasion or ecchymosis across the chest, abdomen, or neck. Thoracic injuries like sternal or rib fractures could occur with lung or heart contusions. Even small bowel perforation or splenic or liver lacerations can occur as seatbelt can cause blunt trauma to them. There could also be flexion hyperextension injury of the spine.
Blood's from a scalp lack. Also complained of chest pain, sleepy but arousable.
What's your name?
Paula.
Heart rate's a bit tacky, 112. BP is fine.
Paul, are you in any pain right now?
Yeah, I got hurt.
Witnesses say she was driving erratically before the crash. No ETOH on her breath.
ETOH means ethanol, meaning this isn't a case of drink and drive.
Maybe drugs?
Core tabs 104.2. Heart rate 116. BP 180 over 110.
The vitals have significantly improved. Only 2 degrees more to lower and she would be put out of the ice water.
Better, but still too high.
Another 4 Ativan.
That'll make 20.
Good counting.
The typical dose for IV lorazepam is 1 to 4 milligrams. We could repeat it every 10 to 15 minutes as needed. Most protocols suggest a cumulative maximum dose of around 8 to 10 milligrams within an hour. 20 milligrams IV within a span of few minutes is indeed too much and can risk respiratory depression, sedation to coma, hypotension, prolonged CNS depression, and is especially dangerous if not in an ICU setting. Even in status epilepticus, 4 milligrams of lorazepam can be repeated once after few minutes with maximum dose 8 milligrams. Then we switch to second-line anti-epileptics.
I heard motor vehicle collision with chest pain and altered mental status. Get my...
Meet Paula. Restrained driver versus telephone pole. Altered before the crash, good BP, but tacky.
Second line and run a liter of LR wide open.
Meaning they're gonna insert a second IV and administer ringer lactate. Wide open means fully open IV roller clamp, so the fluid runs as fast as gravity allows.
Still tacky at 115, BP's 180 over 72.
Airways patent.
Good breath sounds bilaterally.
Pupils are equal and reactive.
Paula, do you know what today's date is?
Checking orientation with respect to time.
That's 94%.
How about the city we're in?
It's
She's oriented with respect to place and person.
bruising on the chest. Possible sternal fracture.
In all cases of trauma, we do a fast scan ultrasound to look for collection of fluid in body cavities like pleura, pericardium, and peritoneum. Here, the heart is being visualized on ultrasound to look for pericardial fluid in the pericardial space. Fluid in pericardium could suggest pericardial effusion or even cardiac tamponade if the right ventricle is collapsed during diastole, which needs emergency decompression percutaneously.
Cardium's clear.
Good.
No marked tenderness. Nothing in Morrison's pouch.
Again, Morrison's pouch is an important anatomical area to be evaluated on fast scan. It means the hepatorenal space between the liver and the right kidney. Fluid in it suggests peritoneal effusion. It's the most gravity-dependent area in a supine patient on the right side, so peritoneal fluid will collect here first. Other areas to evaluate for peritoneal effusion would be splenorenal recess between the spleen and left kidney, or the recto-uterine pouch of Douglas between the rectum and uterus.
She's a little tachypnic.
I don't think she needs intubation. Might just be concussed.
I worry about her crumping in the scanner.
She's protecting her airway. I see lung sliding, no pneumo.
On ultrasound, the visceral and parietal pleura appear as a bright, shimmering line, and when a person breathes, the visceral pleura glides over the parietal pleura, creating a back and forth motion called lung sliding. This is a normal finding and means that the pleural layers are in contact and no air is trapped in between them. Hence, we can rule out pneumothorax in that area if lung sliding is present. If lung sliding is absent, it raises suspicion for pneumothorax because air in the pleural space separates the pleural layers, so no sliding is observed.
With a head injury?
You guys are supposed to be the airway experts. Stop fighting. Make a decision. Call me when she goes to CT.
Tachypnea can be an early warning of neurological deterioration, shock, or respiratory failure. In a head injury patient who is tachypneic, the need for intubation depends on several other clinical factors. If the Glasgow Coma Scale is 8 or lower, intubation is strongly indicated to protect the airway. Intubation could be done if there is inadequate ventilation or oxygenation, risk of aspiration, or increased intracranial pressure.
Can you raise your right arm for me?
Good sign follows commands. You want to intubate with a GCS of 13.
I guess 13 is E3V4M6 here. GCS 13 is quite good for a trauma case that also likely includes head trauma.
Okay, we can hold off and monitor. What's your plan?
Pan scan, head to pelvis.
To rule out any internal organ injuries along with fluid collection.
EKG, troponin.
To rule out blunt cardiac injury potentially causing arrhythmias or myocardial injury.
Straight cath urine for UA and tox screen.
Straight catheterization is used to collect urine for urine analysis to check for infection, blood, ketones, myoglobin, and so on. Tox screen is urine toxicology screen used to detect drugs like opioids, MDMA, cocaine, benzodiazepines, or THC. Straight catheter is used since the patient is not able to void by herself in this case. Also, it's a one-time in and out catheter, so it avoids leaving an indwelling Foley, which reduces risk of infection.
Agreed. I'm on it.
Gotta bend those knees.
I quit showing off.
Is that what you were doing?
Always.
It's a 10-day course of doxycycline, 1 pill twice a day.
As pointed out in earlier episode, the treatment of chlamydia includes antibiotics like doxycycline 100 milligrams orally twice daily for 10 days. Both the sexual partners are to be treated simultaneously. Patient is asked to abstain from sex until treatment completion and symptoms resolve, and also advised for regular condom use and avoid multiple sexual partners.
I'll make sure she takes it on a full stomach.
I can give you your first dose now, Piper, if you like. Get you started.
That'd be great.
I need Piper to answer that one.
Sure, that'd be great.
Okay. Hello, everyone. Looks like we're finishing up here. I come bearing gifts, everything you always wanted to know about STIs.
So, this is a case of chlamydial infection. There are other STIs like gonorrhea, syphilis, herpes, HPV, HIV, hepatitis B and C, trichomoniasis, and so on. STIs can complicate into pelvic inflammatory disease, which means it can spread from vagina or cervix to uterus, fallopian tubes, and ovaries. The infections could disseminate as well, like disseminated gonorrheal infection. Some have no cure. So, it's always important to avoid multiple sexual partners and use barrier protection at all costs.
But no one wanted to read. No gross pictures, I promise.
I think we're good.
You sure?
Mm-hmm. Yeah, I learned my lesson. It won't happen again.
The girl is oddly reluctant to basic stuffs and even reluctant to doctor's counseling. It's just a weird vibe.
I guess that's it then.
Well, if you change your mind, comes with a free pen.
Thank you both so much for your help.
Yeah.
Thanks.
Okay. Good luck to you both.
The doctor trying to help is effectively shut down by the patient and her boss. This is an extreme case, but we do come across situations where we're trying to help, but the patient doesn't actively want to understand or just won't listen. We separate patients from patient party and still no effect. At that point, we are rendered helpless to help and can't do anything.
That sums it up.
She'll be back. Only she'll have slipped a little further.
Sometimes it takes a few visits.
In general, apart from cases like this, sometimes it definitely takes few visits to convince a patient that the meds we gave actually work and to ensure good compliance of the patient with medications we prescribed. Also, it definitely takes few visits for a patient to process that the surgery we indicated for them is actually important and must be done. It might take more than a few visits for the fight bite patient to make her understand that masks actually work. So, it is what it is.
How can I keep her here? You got anything?
Maybe Kiara has a social services card to play. She was by Trauma 1 last I saw her.
Brilliant. Brilliant. Thank you.
That's why I'm here. To be brilliant. And bring peace.
This scene shows that medicine is not just about providing medications or performing procedures to fix the patient's disease. It's about helping patients overall, and doctors would definitely do whatever it takes to help those in need, sometimes stepping out of their domain. But there is only so much we can do outside of our profession. Maybe informing concerned authorities to keep a watch at the duo could be done.
Heart rate's 84, BP 126 over 78, pulse ox 99 on room air.
Good news, Mr. Purnell. Your heart, lungs, and belly all look good.
Fast scan ruled out pericardial, pleural, and peritoneal effusion is what he actually meant by that.
Yeah, just the leg.
Ooh, this might be a road rash record. We might have to bust out the tape.
It's a pretty gruesome looking injury. These are called grazed or brush abrasions. They occur when the skin is scraped against a rough surface, like concrete, resulting in a wider area of skin damage.
The knee looks stable. There's no laxity to suggest a torn ligament. I think the pain's probably just from the road rash, but let's get an x-ray just to be sure.
Yeah, we can only rule out so much from just observation and examination. X-ray of the leg would confirm presence of any injuries or fractures.
Some more morphine?
You're a wonderful human being.
Let's start with LET, no more than 30 cc.
LET is a topical anesthetic mixture commonly used to numb skin and mucous membranes before minor procedures. It stands for lidocaine 4%, epinephrine 0.1%, and tetracaine 0.5%. Lidocaine acts as a rapid onset, intermediate acting local anesthetic, while tetracaine is a longer acting one, and epinephrine is used as it causes vasoconstriction and reduces bleeding to provide a bloodless field to work with, and also prolongs anesthetic effect. This mixture is applied directly to the open wound. It is commonly used in pediatric emergency settings before suturing lacerations.
We're gonna try a topical anesthetic to numb the raw skin before we start picking out all the gravel.
Wow, my morning horoscope didn't mention any of this.
Well, hey, look on the bright side. Now you can tell people that you got hit by a car. Not a lot of people can live to say that.
Look for silver lining in a cloud, I guess, is what Dr. Langdon means to say.
Yeah, I hope whoever hit me is rich and well insured.
Flag on the play. Positive pregnancy test.
That's a twist to the entire case. CT wouldn't be done in this case. But how come was it not detected in the scan before then? In the pelvic view of the fast scan, you are visualizing the pouch of Douglas for free fluid. And yes, the uterus is typically seen in transabdominal view.
Still want to scan?
Maybe she's bleeding from an ectopic.
But since the fast scan was clear, there was no bleeding in the pouch of Douglas, which would suggest rupture of ectopic pregnancy.
No, she delivered a healthy baby here 10 days ago. Normal vaginal delivery, no complications. Pregnancy tests stay positive for a few weeks.
Pregnancy tests detect HCG or human chorionic gonadotropin, a hormone produced by the placenta. After delivery, HCG doesn't disappear immediately. It gradually declines over 2 to 4 weeks, sometimes even up to 6 weeks. So at that time, UPT can still remain positive.
Are we good to go?
Good to go. We'll let the tech know.
Since there is no pregnancy, CT can be done.
Oh, man. She was seen here this morning by Dr. McKay.
For what?
Urinary tract infection. Discharged with oral antibiotics.
Think it has something to do with the crash?
Yes, no, maybe.
What could be the relation between a UTI and a crash?
Ask me again after I've had the scans, labs, and tox screen.
Okay, so I need to talk to you about something.
About what?
Do me a favor. Look at me and don't turn around and just walk straight into... I told you not to turn around!
Rats in a hospital workplace are a serious public health hazard. They carry risk of infections like leptospira, salmonella, hantavirus, plague, and more. Their urine, feces, and saliva can contaminate sterile environments and instruments and compromise patient safety.
I wish there was a way to keep it, but there just isn't.
Well, then just say that we need another urine sample, that the lab left the last one out too long and couldn't culture it.
But you can only keep a patient for so long in the hospital without proper indication to do it.
Okay, then what?
I'll give Piper the sample cup and send her down the hall to the bathroom. I'll stay with Laura in the room with some bullshit. You wait for Piper by the bathroom.
To say what exactly?
I don't know. It'd just be another voice saying, I see you're in danger.
I don't think she would respond at all, and the determination of the doctor to help whom she thinks is in danger is to be appreciated, but like we said before, there's only so much we could do as doctors. We are limited by medical ethics and law too.
There are limits to what we can legally do, but I can try to talk to her.
Hi, it's Dr. McKay again. Can I come in?
Sorry.
Yeah. Well, it's a long shot anyway.
It definitely was. The girl was given several chances to open up, but since she was still very young, she didn't understand what was going on.
I think Piper took a pen.
That's the result of repeatedly insisting that she needs help or might need help. Repetitions actually work during patient counseling in general. Might take a few visits, but patients eventually understand why the doctor keeps insisting on medications or a procedure or even certain lifestyle changes.